All right, we're back. Senate Health and Welfare. And the clerk is in charge.
Yes, so we took an initial vote, but there was one senator who was absent. We want to make sure that we support her vote. Senator Hardy, how would you like to vote on the occupational therapy compact?
Yes,
Wonderful.
thank you for.
Yes,
Perfect.
voting it out 5-0-0.
Perfect. And Senator Weeks is a reporter. And tomorrow we'll look at the social work compact bill with an intent to possibly vote. Possible intent, an intent to vote. That's right. All right, so we have 766 and the reporter of the bill will be coming in. Jen, why don't you come up and we might interrupt you. We'll see where we get to, but we would like to have Alyssa Black present. So as an introduction, why don't we do a higher level intro? Then when Representative Black is in, we'll go to her and then we'll come back and perhaps do a little more detail, but we also have Fisher scheduled to testify too. So we have time for all of that. Thank you.
Great. Good morning. Jennifer Garvey, Office of Legislative Counsel. Do you want me to put the language up or do you just want to?
Yes. Yeah.
Plan ahead this time, so I'm already in the Zoom. Okay, so here you can see H 766 as passed by the House. This is an act relating to prior authorizations and step therapy requirements, health insurance claims, and provider contracts. So we're really in a health insurance world here. Section 1 amends 8 VSA 4089I. This is a section of statute on health insurance coverage of prescription drugs. And this makes some changes to the provisions on health insurance plans that use step therapy protocols in their prescription drug coverage. Step therapy, which you'll probably hear more about from others, but is just the general idea that somebody would have to take a certain drug or certain type of drug before taking perhaps a more expensive one. So there are certain steps to go through before reaching the most expensive or the most the hardest, for some reason less favored drug.
Does it just apply to prescription or is it also procedures?
This piece is just on prescription drugs. We're gonna get to some of the prior authorization provisions that are for prescription drugs and for procedures and things like that a little bit later. So we will look at the language on that later, but this is kind of the substance of general substance of section 1. Section 2 amends 18 VSA 9418A. And this is, oh, here we go.
Oh, so this is a good place. We were doing a 10,000 foot overview. And we're going to stop because we would like for you to introduce the bill.
I'm
Senator
sorry.
Black.
I thought I was being proactive by being here 2 minutes early.
You
but
are, well,
Apparently.
we found ourselves with extra time.
Or yes.
Glad you're here. Thank you.
So, for the record, Representative Alyssa Black, co-sponsor of H 766. And also I reported this bill, for the House. So thanks for taking it up. I think, obviously Jen's gonna do a walkthrough with you and explain all the sections, but. You know, I think the overarching theme was, we hear over and over again from providers. That, like, what is crushing them right now is administrative burden. And I will say personally, I worked, I use that past tense. I worked for over 30 years in healthcare administration, specifically billing and procedures around prior approvals. So I have watched in my 30-year career, you know, there was a day when a clinical provider provided clinical care. And there was a day when an insurance company or a payer paid for the clinical care. I think what we've seen chip away over the years is this sort of integration of payers now mandating or providing clinical care and clinical providers basically just doing administrative tasks. I mean, I'm not so old, but I remember a day that there was no such thing as a prior authorization. The first prior authorizations that I can remember were on the back of someone's insurance card where it said, if you're going to be admitted as an inpatient, you had to call the insurance company. There was no prior approval form. I remember the advent of HMOs where primary providers had to send a referral in order to go to a specialist. That slowly went away and it became replaced with services, any service you wanted to provide to your patient that you felt that they needed, that was clinically warranted, had to get permission. And it has had a demoralizing effect. You are trained, go through, think of the years of school you go through. Think about the continuing medical education, the board certification. Every single step, somebody is asking you, prove it. Justify that to us. So anyways, the bill. It's got a couple pieces and they're a little bit disparate, but they are all these sort of administrative tasks. So first section of the bill really goes into step therapy. I'm not sure if you all know what step therapy is.
Some of us are, and some of us aren't.
Yeah.
Yeah, well,
So step therapy is essentially, and this is usually on medications, although there are prior approvals for other services that they require that you do this to get this. But essentially, formularies, all payers have a formulary drug list. And they're like, these are our preferred, these are our tier 2, here's our tier 3. And that you have to start with this one and work your way up and have someone fail on medication. But think about the Hippocratic oath of first do no harm. We're literally putting providers in the position of saying, first do harm before you can then do no harm. And this bill does not eliminate step therapy. All it does is it essentially says, if the clinical opinion of that provider is that this medication is not warranted for this patient, and here's why, that is the exception to step therapy, and that is the final arbitrator of step therapy. So that's what really the first section is. Section 2 is about claims processing. This is my jam.
Never would
I
have.
am the only one that gets excited when we start talking about.
Oh, no,
coding.
there are a couple of us who did, so.
Yes. So I really encourage you all to take we have some really powerful testimony from providers. And this is, I don't know if you all are aware, you might have received communication from providers in your communities, constituents. Essentially, an insurance company has the ability to change at will how they want things coded. And last year, in January of 2023, one payer instituted sort of and I'm sure they can go into it in more detail than I can. They instituted sort of a third level claim check. And it opened this can of worms for prepayment review, which is essentially if you send a claim in and it has a certain particular code that this payer identified as something they wanted to look at further, And it really gets around things of when you're doing multiple procedures at the same time as another procedure. That they just did a blanket, well, they don't call it a rejection, but essentially when a provider gets it back, they see it as a rejection in their system. And it's just like, prove it to us. And this massive administrative nightmare, sending in notes to, by the way, a system that was not set up. And I think things were going to a fax number that didn't even exist. And there was no ability to appeal. There was not really any communication about how to appeal. And we took testimony from very tiny independent providers who only have maybe one staff member to do all their administrative tasks. And they had to hire 2 additional staff members full-time to just deal with these audits. When you talk to our largest hospital system in the state, they will convey to you the tens of millions of dollars that this involved, that they then had to appeal, and they're still working on the backlog of those appeals. So I really encourage you to go in and, or take testimony from payers affected by this, because this was a big deal. Essentially, what this section does is it sets, it's an alignment of claims edits. So, you know, the kind of the overarching theme of this bill is if you can align across all payers, and you all know just as well as I do that we control a very, very tiny segment of the healthcare market. But if you can start aligning Medicare and Medicaid, which are largely aligned anyways, and then you can bring the individual payers into that, now you're talking about a big section of the pie. So if everybody is working under the same rules, then providers have the expectation of, I know how to do this. This is how this person wants it, I call it person, how this payer wants it coded. When they're all being coded the same way, then it's really increases, you know, your efficiencies. So this aligns to Medicare for the types of services that Medicare pays for. It has exceptions for all other types of services that Medicare doesn't necessarily pay for. So, and then section 3, I'm sorry, it's been a couple weeks since I reported on this, and I can't remember which section 3 was. Jen? Yeah. Prior authorizations.
Right.
So prior authorizations, we took testimony from DEVA. And with the pandemic, DEVA suspended massive swaths of services that required prior auth.
We did that.
Oh, yes, that's right, you are right. And you know what they found out? Utilization didn't increase at all. And they didn't reinstitute them.
You say that again, sorry, from the beginning.
So DEVA, so at the beginning of the pandemic, Medicaid stopped requiring prior approval on large amounts of services, things like advanced imaging, you know, like MRIs, CTs, things like that. And they've been in place for years. But that's how business is done. And during the pandemic, and even when services, you know, healthcare services rebounded back to their usual numbers, they found that people aren't just willy-nilly ordering more of these. They're not paying for more of these. And so you've got this, you know, you've got the insurance who has all these people who are going through these. You have every single provider who is filling these things out and going through all these hoops. And it turns out it's really all for nothing. So they did not reinstitute many of these. So this section, we have essentially said payers need to align their prior approvals to Vermont Medicaid. The reason we can't align to Medicare is because Medicare actually doesn't require prior authorization at all. So, there are exceptions for certain things, and like, we can't do it with medications, unfortunately, because every payer has a different formulary based upon what their pharmacy benefit manager has negotiated, so, you know, that proves to be a little complicated. You have services like out of network services, because every payer has different networks, so that can't be aligned. But essentially what it does is it is for the services that Medicaid requires prior approval on. Commercial payers can continue to require for those services. And then the other exceptions in there, but other than that, you're going to, I can tell you from somebody who has done the prior approval process thousands of times. Every payer requires prior approval on a different service, and they all have different clinical things that they want to know, indicators for you to get through that prior approval. So what you end up doing is you're just like, I got a patient and they gotta have this. I don't know if it needs prior approval. You can't tell. They all have these third-party vendors. You can go through an entire prior approval process on a computer through a third-party vendor. And at the end, 20, 30 minutes later, it says, this service doesn't require prior approval. And so what you end up doing is you just throw everything at it. Every payer, you just start the process and all find out, yeah, we do, or no, we want to see this. We want you to do this first. Another payer says, no, we want you to do this first. This aligns it with Medicaid. Again, aligning. That's it. There's some sections in here about contracts. That's what we're trying to do.
That's
we
what
can't-
we've been trying to do.
In this case, that's true.
All cases.
You know, there are these reports in here. Basically, we want the payers to come back to us in a couple of years and tell us, how did this affect you? If it's been a disaster, then we'll know in a couple of years. Same thing with providers. It's a little more difficult for you to prove a non-event. But tell us how this bill has affected you. I think the thing is, I did a lot of research on this bill. And thank you, Madam Chair, because I had a lot of information to work with. Because this has been an ongoing effort for a long, long time. And we have a lot of data, and we've done a lot of studies, and we've done a lot of working groups and a lot of reports. And this is basically saying, okay, it's time. And I'm willing to be the first person to say 2 years from now, listen, that was a disaster. You want, we can come back and we can repeal it. Right? But we're never, ever going to know until we try. And right now, our provider community is struggling beyond your wildest imagination. When you're spending half of your time in documentation and in administrative burden, it is demoralizing. You're a provider. You spent years. You don't go to med school because you don't care for patients. You go because you want to care for people. And when you're no longer caring for people, you retire. That's what you do. You retire. So anyways.
So can I ask you, the vote out of committee?
Vote out of committee was 11-0-0. And the vote on the floor, a second read was a voice vote, which was a unanimous voice vote. And we did a roll call the next day, and the roll call was 137-0 in favor.
Thank you. Thanks for your good work.
Thank you, and thanks for taking it up.
Senator Williams had a question.
Thank you, testimony. we're getting a lot of input from constituents on. The biggest one, I think that, I got from one couple of my constituents just this morning is, you know, our insurance has gone up. Did you get a JFO note with this, for our cost?
I don't believe there was a fiscal note because this does not affect in any way, shape or form the revenue of the state. This does not change anything with Vermont Medicaid. So, yeah, this bill doesn't cost, and the hope is that this will actually lead to cost savings when you start taking testimony from providers and you hear the horror stories of things that have happened with patients of theirs. I mean, so much so ending up in ICUs because of, you know, a prior approval process on a medication and the person stopped taking the meds for a week because they couldn't get it. And they end up in an ICU for a month. I can tell you from the practice I worked at, and this is generally across, all. I'll just give you a perfect example. In order to get an abdominal CT, you have to have a prior approval. So if you're a primary care physician, think pediatrician, family medicine, anything, and you have a patient that comes in with like severe abdominal pain and a high fever, and on physical exam, your first suspicion is appendicitis. You cannot get an emergent prior approval on a CT, which is all they need in order to be able to diagnose it, so that you can then get them emergently to a surgeon, the surgeon on call. You can't do that. So instead, what you do is you send that patient to the emergency department, because the emergency department can get a CT without prior approval, but only them. So, you know, it is the hope that if you're providing the right care in the right setting with the clinical judgment of the provider, that patient outcomes will be better. And therefore less expensive. And
Thank you. That's terrific. Thank you very much. And so we know where you live.
yes,
Downstairs.
right upstairs, 2 floors.
We'll find you.
Two floors.
We appreciate your
I
time.
know, if you don't mind, I'm gonna sit and go through Jen's, or listen to Jen's walkthrough.
All right, so why don't we do that? We'll have Jen go through maybe at a slightly lower level.
Okay,
And then, Mike Fisher is here, to testify after that, and then we'll move on to H72.
I to leave to go to meet if not walking out.
oh. Okay, all right, we'll go down a little lower. You have, I think, a better sense now for what step therapy is, so we can look at the language. Under existing law, there are some provisions around step therapy that say that a health insurance or other plan offered by a health insurer or pharmacy benefit manager that provides coverage for prescription drugs and uses the step therapy protocol. And under existing law, they cannot require failure, meaning it doesn't work. There's some reason it's not the right fit on the same medication on more than one occasion for continuously enrolled members or subscribers. And then in the existing law, it goes on to say that nothing in the subsection shall be construed to prohibit the use of tiered co-payments for members or subscribers not on the step therapy protocol. And then there's a very specific provision around treatment for substance use disorder. So this expands on those provisions by saying that the insurer or other payer shall not require failure. This gives some examples, including discontinuation because of lack of efficacy or effectiveness, diminished effect for an adverse event on the same medication on more than one occasion, and then this is clarifying a bit what continuously enrolled members means, because we're gonna have a slightly different provision in the later part. So for insureds who are continuously enrolled in a plan offered by that insurer. So if it's the same insurer or at PBM, then they can't require failure on the same medication on more than one occasion. We're explaining what that looks like, or some examples of what that would look like. And they have to grant an exception to step therapy protocols on the request of the insured or their treating provider under the same time parameters set forth for prior authorization requests, which you're going to see coming up because we're making some changes to those. If any one or more of the following conditions applies. If the drug that would be required under the protocol is contraindicated or is likely to cause an adverse reaction or physical or mental harm to the insured. If the drug is expected to be ineffective based on the insured's known clinical history, condition, and prescription drug regimen. If the insured has already tried drugs on the protocol or other drugs in the same pharmacologic class or with the same mechanism of action, and those have been discontinued because they didn't work, lack of efficacy or effectiveness, diminished effect, or an adverse event, regardless of whether the insured was covered at the time on a plan offered by that insurer. So this is where we're making some distinctions between same insurer, ongoing, or different and potentially a different insurer. Or if the insured is stable on a prescription drug that their provider prescribed for them for that same medical condition under consideration. Or if the protocol or a drug required under it is not in the patient's best interests because it will pose a barrier to adherence. So it might be challenging for the person to continue taking that drug, or it's likely to worsen a comorbid condition, likely to worsen something else the person has going on medically, or it's likely to decrease their ability to achieve or maintain reasonable functional ability. For example, it's going to make them very sleepy, and they wouldn't be able to perform at work. And then we have the existing provision that doesn't go away about not prohibiting the use of tiered co-payments if there's not a step therapy protocol applicable. And then just a few little tweaks to the existing language with a particular carve out on substance use disorder medication. That's section 1. Section 2 gets on to the claims processing and claim edit standards. This is the part that Representative Black got excited about, just to remind you where we were. And so this amends some of the provisions about how health plans and other payers pay healthcare claims, including how they apply claim edits. So the language says, except as provided in subsection C, which we'll look at in a moment, when editing claims, the payers, I'm just going to use that as the broad category here instead of giving you the list every time, shall not require more than the following edit standards, processes, and guidelines. And so this is, as Representative Black was saying, for what Medicare covers. So for claims for outpatient and professional services, the National Correct Coding Initiative as in effect for Medicare, and that acronym is spelled out above. So that's outpatient and professional services, not doing anything more than the National Correct Coding Initiative as in effect for Medicare, so alignment with Medicare. For facility claims, again, aligning with Medicare, the Medicare Code Editor as in effect for Medicare. For pharmacy claims, appropriate nationally recognized edit standards, guidelines, or conventions. And then for anything else, other appropriate nationally recognized edit standards, and this is actually from existing law, guidelines or conventions approved by the commissioner. And the commissioner here is Department of Financial Regulation. And then it gives some kind of implementation provisions in case Medicare makes changes. So for outpatient services, professional services, and facility claims, the ones we aligned with Medicare, the payer is directed to apply the relevant standards, processes, and guidelines that were in effect for Medicare on the date of the claim submission, except if Medicare recently made a change. If Medicare changed an applicable edit standard, process, or guideline within 90 days before the date of the claim submission, then the payer can use the version, the old version, the version that Medicare had applied before that most recent change, if the payer has not released an updated version of its edits. So I'm gonna pause here for a moment and sort of sum this one up. Because some of what we were finding as we're working on this in the House Healthcare Committee is that there was interest in kind of providing notice, but having these processes keeping up with the processes that are aligned within Medicaid and Medicare, and how do we operationalize that? So this is a lot of language to say, the payer still has to proceed with the notice requirements that you'll see coming up. So we're gonna aim for alignment with Medicare, but if Medicare makes a change, there's a little wiggle room there while, for the plan to update its standards, because it has to comply with the notice requirement. So it's a little wordy, but that's what it's saying. All right, so you might remember at the beginning of subsection B, we said except is provided in C. Now we're gonna get to the C. And so C says adherence to those edit standards in B is not required, and a lot of this is existing law. It's not required when necessary to comply with state or federal laws, rules, regulations, or coverage mandates. Not required for edits that the payer determines are more favorable to providers than the edit standards in subsection B, or to address new codes that are not yet incorporated into the payer's edit management software, as long as those edit standards are, and again, this is all existing law at this point, developed with input from relevant Vermont provider community and national provider organizations. New language must be clearly supported by nationally recognized standards, guidelines, or conventions approved by the Commissioner of DFR. And they have to be available to providers on the plan's websites and in its newsletters when it adds or equivalent electronic communications. All right. Then we've got the how often are new edits released. It says payers cannot release edits more than quarterly, and it specifies the dates. They could take effect January 1st, April 1st, July 1st, or October 1st. And the edits cannot be implemented without filing with DFR to ensure consistency with nationally recognized standards, guidelines, and conventions. Should be a comma there. And at least 30 days advance notice to providers. And whenever Medicare changes one of the standards, processes, or guidelines that applies to the ones we said must be aligned, then the payer has to incorporate those in its next quarterly release of edits. Does this make moderate sense so far? At least, all right. I just want to put this
Questions?
here.
Is there a question? Okay, good.
Right, all right, then we have except as otherwise provided in subdivision 2. No payer is allowed to subject a healthcare provider to prepayment coding validation edit review. And this is one of the things Representative Black was explaining, which is helpful to understand it kind of in context. The definition given here is any action by the payer or anyone acting on its behalf that requires the provider to provide medical record documentation in conjunction with or after submission of a claim for payment, but before the claim has been adjudicated. So prepayment coding validation edit review. It says except as otherwise provided in 2, that's not okay. 2 says, but nothing in this subsection shall be construed to prohibit targeted prepayment coding validation edit review of a specific provider group, or facility under certain circumstances. And that might be evaluating high dollar claims, verifying complex financial arrangements, investigating member questions, conducting post-audit monitoring, addressing a reasonable belief of fraud, waste, or abuse, or other circumstances that the Commissioner of DFR determines through bulletin or guidance. So it can't be a general practice, but if there's a particular instance in which it makes sense, it continues to be allowable. All right, then we go on, we just have some subsection 3 designations and references as well. And then we get to a couple of updates here. So in what would now be subsection J, if a payer is adding an edit under subsection B or C1 or 2, so under some of the earlier provisions, they have to publish on their provider website and in their provider newsletter. And that's where we added again, or equivalent electronic provider communications. And then a lot of this is existing law, the name of any claims editing software product that they're using, specific standards that they use for claim edits and this adds, and how those are supported by those specific standards. Existing law has payment percentages for modifiers, and then the specific edit or edits added to the claims software. So this is just kind of narrowing down that wordiness. All right, and then finally, in this section on page 9, in existing law, there was a working group requested that Blue Cross Blue Shield of Vermont and the Vermont Medical Society were requested to convene. This was enacted I think it was 2009. So this kind of continues that concept with a bit of modification, and then later on you'll see it sunsets. So it establishes a working group that has the health plans, contracting entities, covered entities, and payers who are subject to some reporting requirements in existing statutes. So these are the ones that have a larger part of the market share for major medical health insurance, so sort of are the more major players in the health insurance space. Representatives of hospitals and healthcare providers, representatives of DFR and other relevant state agencies and other interested parties. That working group is to study, and it sort of updates what they had been studying. So they are now to be looking at trends in coding and billing that the payers are seeking to address through claim editing. And they're supposed to provide a progress report, not an annual report, but a progress report to this committee and others upon request. Some updates there. Section 3 is also is where we get into prior authorization. There's 2 sections dealing with prior authorization. They actually amend the same statute, 18 VSA 9418B, but in different spots. Yep.
So I'm gonna suggest we have, until I'd like to have some picture.
Go to the very high level.
Could just go up
Section by
slightly
section.
higher level with this one,
All right,
and then
so
be able to get there.
So this section expresses legislative intent to reduce variability in prior authorization requirements by aligning as much as possible with Medicaid. And it prohibits plans from imposing prior authorization requirements that are more restrictive than would apply under Medicaid. But there are some exceptions in place. So prescription drugs are not subject to that requirement for the reasons explained by Representative Black. It does not require alignment for anything that Medicaid doesn't cover. It does not require alignment or prohibit prior authorization requirements for things provided out of network. And it doesn't require plans to provide this, to have the same provider network as Medicaid. Section 4 is the other part of the prior authorization provisions, and it makes some changes to our existing statutes. This is in part around the timing of responding and what the plan responding to a request for prior authorization. So it reduces from 48 hours to 24 hours the amount of time that a plan has to approve, deny, or ask for more information for an urgent prior authorization request. For non-urgent requests, it maintains the 2 business day response requirement for those requests, but it does require the plans to acknowledge receipt within 24 hours. And at that time, that's their opportunity to ask for any additional information to decide on the request. And it has the prior authorizations approvals being valid for the duration of the prescribed treatment, service, or medication, or 1 year, whichever is longer. But if there's an approval for a treatment, service, or course of medication that continues for more than 1 year, then the plan cannot require renewal of the approval more often than once every 5 years. And it requires a health plan to allow someone who changed plans and is stable on treatment, service, or course of medication approved under their prior plan to be covered out prior authorization for at least 90 days when they enroll in the new plan. Section 5 is on standards for fair contracts between payers and processors. And this specifies, so I get rid of some old language like references to CD-ROM. And it has.
What has a CD-ROM?
Don't you know? The CD.
I know.
The computer.
Ancient history.
Exactly. Why we're updating these. So the main provisions that are being updated here are specifying certain requirements about the content of and processes for issuing and amending policies and manuals that a plan might use to supplement its contracts with providers, including providing notice of a new or amended policy or manual and giving providers the opportunity to object. So it goes into that in a lot of detail. Sections 6 and 7 are some reports asking about the impact of what this bill has done. So section 6 is asking that by January 15th of 2027, insurers with at least 2,000 covered lives in Vermont, so again, our major medical providers, report to committees, including this one, on the impact of the prior authorization provisions of this act on various things during 2025 and 2026, including utilization, premium rates, estimated avoided costs, costs of alternatives that the plan paid for after denying a request for prior authorization of something else, and costs of emergency department visits and inpatient stays that may have resulted from denial of prior authorization request. Section 7 asks organizations representing providers in Vermont to gather information from their members by January 1st, 2025 and July 1st, 2026 about prior authorization as affecting their members and their practice and the members' practices, and then having the report in 2027 at the same time as the insurer report, summarizing and reporting information on the impact of the prior authorization provisions on the organization's members' practices. Section 8 is the prospective repeal of that claims working group. So it asks them to meet together and work on stuff for a couple of years, and then it goes away on January 1st, 2028. And then we get to the effective dates. So the reports and effective date section are effective on passage. The prior authorization timeframe changes would take effect on January 1st of 2025, except with a limited exception for a plan that has to make some technology changes because it does its own internal utilization review process for certain services. It gives them up to an additional year, and the remaining provisions take effect on January 1st, 2025 and apply to plans. Issued plans, healthcare provider contracts, and claims processed all on and after that date.
Thank you. So, as we take testimony, some of this will gain clarity. All right, good, thank you. So Michael, we do have time. We're not totally crunched today, so it'd be good to get your thoughts initially, and then, well, obviously you'll be able to come back as needed.
Great. Have to come and sit in the seat for a few minutes, Mike Fisher, care advocate. I do want to recognize, I appreciate having the opportunity to come at this time. You're gonna get my initial thoughts and tell you a little bit about where the healthcare advocate has been in this process. But let me do just a little level setting. I and my office often sit between payers and providers as they point fingers at each other for being the reason why our healthcare system is so expensive. And I often end up thinking, well, both sides have a point here. And at the end of the day, people, Vermonters, are the ones who pay the bill and or who are harmed. And so this bill for me, fits that perfectly. I think if I do my testimony right today, everyone sitting behind me will be bad at me. Because I do find myself sort of in between. And so let me just try and speak to, and I, in a few months, my team and I will be holding Blue Cross and MVP's feet to the fire in insurance rate review, ultimately with the question, are you doing enough to keep rates down? Are you doing everything you can? and being critical of them or how much they want to raise the rates. And a few months after that, me and my team will be doing very much the same thing with Vermont students. And so, you know, so I guess I just want to recognize that role. I focus particularly on the prior authorization section of the bill. In the few minutes I have here, I think I want to recognize from the consumer's perspective, the goals of the bill: simplify, make the system work better, are laudable, good. We agree with it. Prior authorization is a place where, even if fully warranted, you know, even if we think, you know, hey, there's a good reason to have a prior authorization here for this service, it's a place where things often go awry. We get calls all the time from Vermonters who say, you know, they might say, my insurance company is screwing up, or they might say, my provider is doing something wrong. It might be that they're right, or it might be that it was the other. You know, ultimately what the person is saying, the system's not working for me, something's gone awry. And so it's a place where there are opportunities for mistakes. I had in my head a recent case where an infant needed care that usually wouldn't require an overnight stay, and it wouldn't require an overnight stay for the procedure had it been an adult. But because it was an infant, the provider said, I want this kiddo overnight. And the carrier said, no, deny the prior authorization. At this, I don't know, you know, this is a perfect example where there's just an opportunity. It could be that the provider didn't code it right, communicate to the carrier that it was an infant, and it got worked out. The child got the care, but the parents lived in stress running up to it, not being sure whether, you know, even the day before, whether it was going to happen. And so I don't know who made the mistake. I'm just saying that prior authorizations are an opportunity for such mistakes. But my main, so the goal of simplifying, or the goal of creating a single standard is a good one. But from where I sit, it has to really work. It gives me great concern to think that the legislature could pass something that we're not sure if it's going to work. And so when we look at the Medicaid prior authorization list, and we see 14,749 lines on that list. And when we look at our cases, the people who call us, and by the way, we get more prior authorization complaints around Medicaid than we do about commercial. Now that might be for a couple of reasons. I want to recognize it is entirely possible that the population of people who are more apt to call the healthcare advocate at Vermont Legal Aid or on Medicaid. We just don't know the answer to that question. It's also true that Medicaid requires prior authorization for out of state. Medicaid is not transportable out of state. And so without prior approval, and that is a place of tension that drives many of the Medicaid prior authorization calls. So that's a dynamic in Medicaid that I think is just not true in commercial. But when we look at that list of Medicaid prior authorizations, we're not sure it's better. Though let me recognize, I think what I have heard providers say here is we just want a standard.
The one,
A standard.
yeah, the one that have everything aligned.
Right, they want alignment, they want a standard, and again, that makes sense to me theoretically. I just am not sure that, and I have heard the testimony, you'll hear the testimony from the carriers. I'm not sure it works to say, just do it like Medicare. And, so I think maybe well, and one more point that I think is really important to make here. We only regulate a very, very small part of the commercial market. And, the state. Wherever we put pressure on that part of the commercial market, we risk, pushing people out of the regulated market. We risk pushing people into self-funded funds. And I will be the first to be critical of carriers for their practices around moving people to self-funded or allowing very small businesses to be self-funded. I think the state is remiss in our regulation of that. And I'll never be successful in that fight. The legislature will never agree with me that we should close the door on small businesses going to cheaper plans outside of state regulation. I've fought that battle before. I'll fight it any day I get an opportunity to. I'm gonna lose. I just want to be clear because really good friends of yours, small businesses, will say, don't take this option away from me. And but nonetheless, if we have a dynamic where if we put pressure on the regulated market, we will push more and more businesses out of the regulated market. And again, you might attempt to be critical of all sides here. Businesses as small as 5 employees are being marketed to become self-funded.
That's not in the bill.
It's not in the
Not in the bill.
I'm just saying- I'm just saying
it
it is
Yes.
part of the structure that we live under that gives me pause that if this, I can't tell you, I am not able to do the analysis to tell you whether what the carriers are going to tell you is correct or not. But if it does put a lot of pressure on rates, we run the risk of pushing more people outside the small market, small business market. Well,
I think Senator Gould has a question.
I'd like to ask them questions that also get to the very heart of what we're talking about, because you rightfully said we live under the system, right? And I've lived under other systems, so I can compare. But why do we have prior authorization? I want to know why they exist, because I've lived in countries where they don't. And my colleague mentioned that there was a moment where we did away with them and there wasn't a lot of change. So can you just explain to those of us here why they exist?
I can explain to you that
In 2 seconds.
why they exist. I think that the carriers and Medicaid will say that they exist for multiple reasons to deal with high cost claims, to keep a watch on.
Yeah, go ahead, finish up,
And
because I will comment.
For patient, they will say for patient safety, they will say for appropriate care. They will even say, and there's some parts of this that I'm sure is true in each case. They will even say to be a watchdog on their members having expenses that are not saving members money, not having care that.
So, and just think about the fee for service world, where in order to accomplish one's income, get an income that would support the office, the administrative costs and the administrative burden that's placed in a medical facility, then increased numbers of services were the way to go. And so for a while there, we talked about how an increased number of services were actually, it could have been decreasing quality and could have been increasing costs because services were being offered that may not have been appropriate. Therefore, our insurance payer said, wait a minute, you're offering too many services, so we need to have some prior authorization to look at what you're doing for this particular individual. So that is part of it. Today, we're moving away from fee for service. And so we're in a transition time. But we have also heard from Green Mountain Care Board on a regular basis that administrative burden is number one. I mean, number one for cost. So there's a lot here mixed up in the historical development of this and what's going on. And so I'll stop there. Obviously, I know there are a number of folks around the room who can eloquently speak to this and we'll hear that.
And to your point, that number I gave, 14,749 prior authorization lines on the Medicaid is what they would be doing outside of the Vermont Next Generation Accountable Care Organization programs. They waived a lot of them in their agreement with OneCare.
But this is not simply a one care issue. I mean, I don't want to label it one care because that is an automatic lightning rod to the rest of the world. So I'll be very cautious of that, please.
Well, sorry, I'm just
Yeah, I get it.
telling you what is happening today. It's, that is who they are contracting with. So at any rate, I'll go back to my base message. I agree with the intent of the bill. I agree with the goals of the bill. From our perspective, it has to work. And it can't be so, and I also, the concern about, we too have a concern about, provider administrative burden, because of the cost. But the consumer side of that same coin is, uncertainty and real concern about whether they're gonna be able to get the care.
So it will be helpful if you will stay tuned to Bill as we hear testimony and help us balance those two things that you're talking about. I know it's your world of balance, but it's also our world of balance, so it'd be great to keep this. Senator Williams has a question.
I'll be the guy that asks the stupid question, so I'm looking out into this on this, does this affect, hospital bottom lines? In any way?
Well, sure. Sure, I think it affects provider bottom lines. And I think it has the potential of affecting, insurance company bottom lines. And therefore,
That means it's gonna increase insurance rates.
well, and therefore, in both cases, it has the effect, that the potential of having an effect, good or bad, on what comes out of the Vermonters' pockets.
Thank you.
So thank you, Representative Black, for bringing us this. We've got a ways to go in a lot of directions, and I want to thank the healthcare advocate for coming in. It's difficult, you're in a very difficult position where you see all sides of this, and we appreciate your comments very much. So what we're going to do is we're going to move right into H72, and we'll try to, okay, so we can take 5 minutes. Take 5 minutes, please, and come back.